Good afternoon, everyone. We will start in just a few minutes. Well, welcome to the fourth in the coffee series of the Greenleaf Center for Servant Leadership at Seton Hall University. I'm Reggie Lewis, the center's executive director, and it's great to greet you from our campus here in South Orange, New Jersey. The coffee series provides an opportunity to showcase the inspirational stories of servant leaders. Each of our guests has deepened our understanding of the promise of this leadership philosophy and the endless ways in which individuals, organizations, and society in general can be transformed for the better. And I assure you, our guest today will not disappoint. A leading voice in preventative medicine and public health, Dr. Chris Purnell is the first Chief Strategic Integration and Health Equity Officer for University Hospital in Newark. She's that caring physician that we just need more of. She's responsible for the oversight of health equity strategy development and integrating equity and inclusion within the system and across all operations at the hospital. Prior to joining University Hospital, she led the 1199, I'll try and get it all, Dr. Pernell, SEIU, League Labor Management Initiatives, where she worked with leaders and frontline workers across New York City healthcare institutions to foster worker empowerment and promote equity throughout the city's healthcare system. Here in her home state of New Jersey, her efforts to address prison reform and care for justice-involved populations, along with such issues as evidence-based wellness programs and civic health, are just a few reasons that caught the attention of NJBiz magazine, which named her a public health hero in 2020. Now, admittedly, I'm biased because Dr. Pernell has been my heroine long before the NJBiz honor. A cum laude graduate of Princeton University, Dr. Pernell attended the Duke University School of Medicine and received her Master of Public Health from the Columbia Mailman School of Public Health. She completed her general preventive medicine residency at the Johns Hopkins Bloomberg School of Public Health. Dr. Pernell is a fellow of the American College of Preventive Medicine and holds an appointment as a clinical assistant professor at Rutgers, New Jersey Medical School. She's a frequent contributor across television, radio, and print media. I'm sure you've seen her on CNN. So we know that our time with her today will be a precious treat. But first, a quick word about the center. We were founded in 1964, and for well over 50 plus years, the Center for Servant Leadership has worked to promote the understanding, awareness, and practice of servant leadership, a philosophy in which the leader first seeks to serve. The center offers an extensive catalog of publications, opportunities for online learning through our Greenleaf Academy, workshops, and an annual summit. We'll say more about the center a little later, but let's begin with Dr. Chris Purnell. Welcome.
Thanks for having me. I'm very, very happy to be here. Very happy.
All right. Well, listen, congratulations on being named the university's hospital's first Chief Strategic Integration and Health Equity Officer. Tell us about the significance of this role and the key areas in your portfolio.
Definitely. You know, this is a life come full circle moment for me. As you mentioned, I am a board certified preventive medicine and public health physician and had been working in New York City across multiple institutions and with 1199 SEIU. And the opportunity, I was always living in New Jersey while working in New York, but the opportunity to return to New Jersey and to be able to use my skill set and a population-based practice in my backyard truly is life affirming and life fulfilling. And when I say in my backyard, I literally want people to understand my twin aunts, who are 83 years old, were born in the predecessor hospital, even to Martland Hospital. Okay. So that's how far back. That's how far back. My grandfather had a store on Central Avenue in Newark that actually got riddled with gunfire during the rebellion. And then my mother came and resettled Newark herself personally after they had been living in Virginia right before my grandfather and family came back. She and her big sister came in the late 50s. So an opportunity to be a part of this city's legacy around health and health justice, health equity, and to do it at University Hospital is very significant for me, especially at this time. So I land here in November 2019, and I come at a time that is going to be defining not only for our nation, but defining for our world and globe. And so this office, in addition to being responsible for launching and designing health equity strategy across the organization, thinking about it from the perspective of patients, community, and workers, this office is also responsible for community affairs, strategic planning, community and population health, and the human experience, which is an expanded understanding of the patient experience.
Excellent. A broad portfolio. And again, the first of its kind for the hospital, correct? Absolutely.
Yes.
There are many who say that physicians are often akin to natural service, and we certainly see that in you. Servant leaders in their own right. Say more about what brought you to medicine and what drives your desire to serve.
I love telling this story. If you can imagine a sixth grader in East Orange, New Jersey, a quite intellectually curious Black young girl, and sitting in one of my classes for the day, and we had a guest speaker. I loved going to school in East Orange. I loved being a part of Elma Grammar School. It was a school where I was affirmed. I was affirmed in my Blackness. I was affirmed in my intelligence. And this guest speaker said, there are many roles in healthcare. There are even many different types of physician. And she herself wasn't a physician, but she started to describe the different types of physicians and doctors. And she started to talk about a brain surgeon, a neurosurgeon. And I was floored with fascination, if you can imagine that analogy, right? Being floored with fascination. And from that day, I remember running home. I remember telling my mom, I know what type of doctor I'm going to be. And that was my childhood dream. I think I settled on it, not just because I was intellectually curious. I thought it was hard and challenging. And I was raised by a father with Black power in one hand and Black excellence in the next. And so I was looking to be challenged. And so I spent the rest of my young life thinking I would become a brain surgeon. And it wasn't until I got to my first year of general surgery training at UCLA that I had an epiphany, leaning on the wall of a neuropath conference with my pager going off, questioning how I could be in multiple places at once. I was like, how am I supposed to be at a neuropath conference and be on the floors? And literally in a flash, I said, Chris, you don't want to be a brain surgeon. And I was like, who said that? Like, I looked over my shoulder, and it was my awakening. It was my awakening that I definitely wanted to be a doctor, but I wanted to be a doctor who could combine a sense of service, a sense of community service, a sense of policy, understanding even politics, and how you keep groups of people healthy. And so it took me some courage, and it took me a while to back myself out of one type of clinical training and into another, because population-based care and public health is a different practice. I don't do direct patient care. I look at populations, whether those are regionally defined by race or ethnicity, defined by gender, or some other geographic, demographic factor. So it took me a while to do that, but I am at home in my person and in my profession and in my passion.
That's wonderful. We're grateful for that epiphany, by the way.
I am too.
The University Hospital has certainly done a great deal to support your passion in creating these opportunities just for us to have a greater focus on these issues in Greater Newark. what should our guests, particularly those who are in New Jersey, know about the progress being made at University Hospital?
Definitely, excellent question. So let's back it up a little bit. This role is a culmination of an imperative that was growing out of a strategic visioning and strategic planning process that our board had really launched and mobilized, of thinking what are the healthcare and health and well-being needs of community? How does the organization not just be responsive to that, but lead and dedicate itself to key pillars? And if we're going to talk about community health improvement, very much hand in hand with that, health equity, diversity, equity, and inclusion have to be a part of that, a part of University Hospital fulfilling its mission as the state's only public academic health center, and its vision partnering with communities to achieve health across generations. And so under that guidance, and then with Dr. Elnahal's leadership, our president and CEO, who preceded me by a couple of months in this role, he's saying, hey, I want a role that looks at equity, but equity not siloed in an organization, but working in an integrated fashion. How does equity matter to our strategy? How does equity matter to our bottom line? How does equity matter to our care delivery? And so you should know that University Hospital is an organization that is on the move. And when I say it's on a move, it's an organization being more agile around how it delivers on its mission and vision. University Hospital was definitely shaped in the bosom of the NORC Accords, the NORC agreements, right? That spring up during that time of the NORC uprising. And what is our responsibility? What is our accountability to community? Health is not just the care you provide. It is very much the care you provide, but it's not just the care that you provide. And so in this role, especially during a pandemic, when social needs have been exacerbated, and social and health and racial disparities have been illuminated in ways that none of us can feign ignorance around or ignore. So the hospital is seeking to not only deliver on its mission and vision, to rededicate itself to the spirit and intent of the NORC Accords, but the hospital is looking to realize equity full throttle in a muscular and robust way. So that looks like making sure care is culturally responsive. So we've done our first ever cultural competency assessment. We started with our staff. We're about to mobilize it with our patients and community. We raised our first equity and inclusion governance committee. That governance committee has representation across the organization and partnership with Rutgers, New Jersey Medical School. We're looking comprehensively at the populations that we serve and engage, whether those are workers or patients or community. And ultimately, we're going to publish a health equity or equity roadmap so that all can have awareness of where we're putting our stake in the ground and saying equity means this, and this is how you measure it. This is what success looks like. These are immediate goals. These are more interim or long-term goals. So University Hospital is already articulating what that vision looks like, and benchmarking itself for future growth and progress. And as I was saying, the pandemic really brought to light recently on a recent 60 Minutes, the illustrious David Williams, the professor, is talking about, imagine a jumbo jet crashing. There's about 220 people on board, including the staff. Imagine that crashing. Imagine that happening every day. Imagining that happening every week. And what we know through the literature is roughly 200 Black persons die prematurely every day in this country. Now that reality was known, but the pandemic put it in 3D. And this role at this time allows us to say, how do we lead forward with equity in a reimagined space, in a redefined normal? And what does that look like? So people should know we've doubled down on that commitment. We're making progress on that commitment. We want to be held accountable to that commitment. And we're making progress around multiple areas. We're thinking through our service lines. Are those service lines, on trend or even ahead of trend? That's another one of our pillars, through research and innovation, not just thinking through our service lines, but what is the quality of care? Are we delivering quality care? Equitable care is quality care.
Absolutely.
You can't divorce the two. So we're making inroads in our quality metrics. And while we're making inroads in our quality metrics, we're saying do it through the lens of the human experience. Does everyone feel respected? Is everyone our core value? Or how are teams functioning? How are we exercising reliability, integrity, and stewardship? So those are just some of the things that University Hospital is on the move and committed around.
Fabulous. And forgive me for a question that's not on the list that we talked about,
Sure,
but I'm sure you'd be open to maybe sharing more with our guests about how university, in sort of leading the way, how you are able to think about ripple effects within the sector in terms of other area institutions as they grapple with or consider grappling with equity issues as you all have done.
Definitely. I can tell you when we talk about or think about health equity, we cannot divorce equity from the larger understanding of the social determinants of health framework. Okay, so let me put forth a few definitions for folks. So health equity, as the American Public Health Association defines it, is the opportunity for everyone to achieve or attain their highest level of health. Okay, so if that's our true, we know that health, there are factors that contribute to your health status. A large amount of those factors are found outside of healthcare. Healthcare is responsible for about 10% of those factors. There are factors rooted in your physical environment. There are factors rooted in economic opportunities. There are factors rooted in education, factors rooted in behaviors, factors rooted in genetics. So what we want to be able to say in this health equity space is not just how do we achieve more equitable care, but how do hospitals as anchor institutions become hubs of racial healing? And I borrow that sentence, that statement, that imperative, that mandate, specifically when I'm looking at my board for you all, I look at it every day, from Dean Dana Bowen Matthew. She is the dean of the George Washington Law School and a social scientist. And she's written a book about looking at, the inequalities, American healthcare, like talking about just medicine, talks a lot about implicit bias. I read that every day, hospital as hubs of racial healing. So I say that to say within the sector, we must be challenged to solve for those more ubiquitous, omnipresent, systemic forces in which people's lives are shaped, in which people's health outcomes are impacted if we are going to help deliver on healthier outcomes and healthier populations.
Thank you so much. Let's talk a bit more about what appears to be intractable, longstanding challenges around inequities. Just say more. You mentioned a few stats earlier, but if you could say more.
Oh, definitely.
About, the magnitude of these inequities for our guests.
Definitely. Let me start here. So back when I was at Hopkins, I had a colleague and a friend, and she said, not another disparities lecture. And she said it from a place of Fannie Lou Hamer.
Yeah.
Like, I'm sick and tired.
Yes, of being tired.
Right. And not another disparities lecture, because it had become too theoretical and conceptual, right? They were numbers on a page, data, but it wasn't necessarily telling a story in a compelling way that everyone understood why it was important to understand. And that's what coronavirus did. It ripped the Band-Aid off of our eyes and off of our hearts and off of our intellectual minds. I lost my father during this pandemic. So when stats say, thank you, when stats say that Black women are 2.5 times more likely to have lost a loved one, I look at myself. I look at myself losing my father. Since losing my father on April 13th, 2020, I've lost 2 cousins. Okay. One of my cousins, I'll speak his name, Frankie, Thomas Franklin Boswell Jr., was a postal worker here in Newark. He worked the downtown beat. He worked Wiggums every day, going about Wiggums to deliver mail. Another cousin had a host of chronic health conditions. So I've lost 3 people in my family circle. And my eldest sister, who is a breast cancer survivor, is a COVID-19 long hauler. Those are the disparities that we're talking about. Those are the disparities, and that is not normal. So whether you're looking at the CDC's body of data or you're looking at the Color of Coronavirus project done by APM Research Lab, we know that Black and brown groups, defining Black and brown groups are Blacks or African Americans, Latino, Latinx, Hispanic populations, Indigenous and Native groups are anywhere from 2 to 3.3 times more likely to die of coronavirus than white Americans. Let that settle for people. We also know that if you look at mortality rates within age brackets, Black people die at ages and rates comparable to whites a decade older than them, meaning we're dying younger and in more severe presentations as whites a decade older. So what's aging us? What's given us worse outcomes? And finally, the Brookings Institute pulls out within an age group where I fall, 45 to 54-year-olds, Black and Latinos are 6 times more likely to die than whites. That is an inequity. Yes. It's more than a disparity. So I want people to understand, before I leave this topic, the difference between health disparities and health inequities. Mm-hmm. So if health equity is the opportunity for everyone to achieve their highest level of health, yes, then health inequities are barriers, yes, to those conditions which ensure the environments that can influence, encourage, and shape your health outcomes. Those barriers are unjust. Those barriers are unfair because they are avoidable. Yes. And the health disparities are just purely differences based in demographic factors rooted in those inequities.
Oh, thank you so much. Let's build on that, if you would, if you could share some thoughts about how we use the lessons around the pandemic, almost in a catalytic sense, to build on ways to improve health outcomes for all Americans, but especially among those who are most vulnerable. How can we build on these lessons?
I thank you for that question.
Turn this corner.
Okay, and I'm going to start with this definition. I've followed this woman's work. Her body of work has just been consequential for public health. Dr. Cameron Jones, she defines racism as a system of structuring opportunity, whereby one group is assigned a value based on their skin color or phenotype, where they are unfairly disadvantaged. Another group is assigned a value based on their skin color or phenotype, where they are unfairly advantaged. But here's the kicker. But the strength of a society as a whole is sapped because of the waste of human potential and human resources. Racism is killing us all. It is killing some of us at a more disproportionate and devastating rate. It is impacting our lives in disproportionate and devastating ways, but it impacts us all. And when we begin to understand the societal costs, the emotional costs, the financial and economic costs, the soul costs, because of that system of structuring opportunity, we then say, what are those intentional anti-racist actions, strategies, interventions that there's a social media movement afoot called Everybody versus Racism, right? What are those strategies, actions, interventions that we all can commit to, and what is the role of each sector around? And so that's one of the lessons I think that we're going to leave this pandemic with. I pray we never forget this lesson. I pray we lead with equity and not respond and react with equity. So we need to make sure that people have equitable access to care, equitable access to quality care, and equitable access to the life conditions that shape health and well-being outcomes. Those are 3 different distinct levers. And each industry, each sector has to say, where is my primary role or responsibility? But then what do I do? How can I deliver on some of the goals in those other 3 different levers that I've described? And that, I think, is a collective understanding that we are arriving at. You can't divorce health justice from racial justice, from economic justice, from social justice.
Absolutely. Collective understanding, a collective effort to lead with equity. So rich. Look at Dr. Purnell. When you think about how far we've come since April of 2020, in some ways, one could argue we were compelled to draw closer together.
Yes.
To unite and build community in the fight against COVID. And then obviously in other ways, in many ways, we seem to have drifted apart, becoming a bit more divisive. Talk about your sense of the climate in this country.
Definitely. Wow. Let me start with this first. So you've heard people describe herd immunity, correct? And so you've heard people in public health say, we need to have 70 to 85% of our population vaccinated so we can have herd immunity, meaning we can be safe, meaning the likelihood of transmitting the virus will be so low that the majority of the community, even those who may be unvaccinated, will be protected. I want to put a spin on that term and then think about that in a broader scope. I heard a dear colleague, Dr. Carlos Del Rio, who works out at Emory and does loads around vaccine research, say we need community immunity. And that then in and of itself is different, right? So if I say to you, we need herd immunity versus if I say to you, we need community immunity. And if I say to you, it is our goal to get safe and stay safe, it doesn't matter if I'm safe and I can stay safe, if you're not safe and you can't stay safe, because a virus doesn't respect borders. A virus doesn't respect boundaries. We are literally in this together. Yes. And so that has been one lesson that we have to understand collectively. What is our collectivism? How do we understand the collective spaces that we occupy? How do we ensure that equity meets the needs of all persons around the table? Because if it's not meeting the needs of all persons around the table, then we don't achieve community immunity. Yes. We don't achieve community wholeness. We don't achieve community well-being. And at the same time, if we don't get at the root of an issue, if we don't understand the systems that are at work and the system sickness. So people say, help me understand what type of doctor you are. I tell people, I am a doctor that treats systems. I treat systems. And racism is an example of system sickness. And what we see is that we've had inappropriate interventions to solve, treat, and cure for racism. And I've had this conversation, and one of the persons that I had this conversation with was Professor Eddie Glaude, and shout out to him. And we in this nation have too often been on a pendulum of progress. And as that pendulum swings forward and we achieve verifiable and significant progress, that pendulum swings back in the other direction. I think we need to break the pendulum. And we need to look to achieve transformation. Transformation is different. Transformation says, maybe we build a different system. Yes. Maybe we design a different vehicle. Yes. And until we do that, you continue to see this climate that is tenuous. You continue to see this climate that is fractious. You continue to see this climate that is full with upheaval because we haven't gotten to the root. And we haven't gotten to the root in a way that comprehensively says, how do we redefine and redesign the system?
Absolutely. Several folk in preparation for today's session with you asked, if not pleaded, that I raise the sticky issue of vaccine hesitancy. And so
yes,
in light
let's
of
talk about it.
in light of achieving community immunity,
yes.
How might we be more strategic in making progress in that area, particularly in light of the fact that we almost have like an embarrassment of riches, right? Where supply is actually outpacing demand. So what does Dr. Purnell say to that?
I love having this conversation. So I'm going to start it with my choice and decision to be a part of the Moderna COVID-19 vaccine trial. Okay. I told you all about, my family's personal experience. I lost my dad. My sister was a long hauler. We were in the throes of this unprecedented public health crisis back in March and April, when New Jersey was very much the epicenter, and Newark, New Jersey in particular was the epicenter of this pandemic. And I needed a way to be a part of the solution, seeing how many patients we had in our hospital impacted, and then seeing how patients were scared or afraid or concerned about coming back to the hospital for care. And when we started to ebb in the summer. And so my way to be a part of that solution was to enroll in a COVID-19 vaccine trial. And my family that had endured so much pain and loss said, "Are you sure you need to do this? You shouldn't do this. Don't do this. Let somebody else step forward and do that. It's not your role to do this. We've lost enough. We have borne this burden of this cross enough. Do you need to put yourself out there?" And I use that example because that's what we see in community. It's not necessarily that people don't want to ultimately be as safe as they possibly can, is that they have concerns. They have valid and legitimate concerns. They have concerns because of present day, day-to-day contemporary experiences in healthcare and clinical research. They have concerns because of perhaps issues of historical injustices. And I could list a host of them for you. But it's usually those present day and the accessible, immediately accessible, the stories of the Dr. Susan Moores that have to resort to their phones and Facebook to say, "I'm not getting appropriate care in this hospital. Help me. I'm a Black woman physician with coronavirus. I'm going to die." And unfortunately, she prophesied the outcome of her life. So that definitely is there at a baseline. But more importantly, especially in Black and Brown groups, what we're finding are issues rooted in access barriers, whether the barrier is around information, whether the barrier is around literacy, whether the barrier is around language, whether the barrier is around time and convenience, or whether the barrier is around cost. If you look at the Kaiser Family Foundation and the polls that they've done, and this is also supported in more polling done like with PBS, NPR, and Marist, in Black and Brown groups, you don't see higher rates of wait and see. You don't see higher rates of definitely I will not vaccinate. You don't see that. Actually, you see higher rates of definitely I will not vaccinate in other groups. You see it higher in certain states out west, certain states in the south. You see it higher in rural environments. You see it higher in certain religious affiliations, evangelical Christians. You see it higher in certain political affiliations, Republicans, conservative white men. And so there are other groups that we in public health, and we, in order to establish community immunity, must understand their needs, their reasons for having less vaccine confidence, so that we can help solve for community immunity. The narrative around Black and Browns in particular has been one of hesitancy, where I think the narrative should have been one around equity. It's a framing issue.
Yes.
It's a framing issue, because when we frame the issue around hesitancy, it says to the group who has this learned behavior, rational response to those experiences I've just espoused on, it diminishes, devalues, questions, lessens their concerns. And instead of approaching their concerns with empathy and the science hand in hand, my dad used to say to me, my father was a researcher, self-taught. My father didn't go to college. But my father used to study textbooks and ultimately took classes at Bell Labs in Murray Hill. He started cutting grass. My father ended up a member of technical staff reserved for PhD scientists. My father worked on teams that are responsible for three-way calling, caller ID, call waiting, right? This Black man who overcame the Jim Crow South. He would always say to me, follow the data, follow the science. But at the same time, he was telling me to follow the data, to follow the science, he also would make and ensure that I acknowledged the environment in which that data and that science is often produced. And so I think we needed to do both of that sooner than what we did. We needed to acknowledge with Black and Brown groups, I understand your history, but I also understand the barriers to access. And let me intentionally try to remove those barriers to access. So what you see is, though we had larger wait and sees in the Black and Brown group, those wait and sees have converted to wanting to be vaccinated. And then we encountered an access issue. In communities where trust has been broken, we shouldn't have conversations that lead with how do you build trust, but we should have conversations that lead with how do institutions and organizations demonstrate trustworthiness. That's a different frame.
Certainly
It's a different level of accountability.
Absolutely.
And that's how we have to manage a lack of vaccine confidence and then counteract it.
Absolutely. So rich. Right before we'll move in about a minute to questions from our audience, I'd like to ask you with respect to, again, lessons, and particularly in terms of how you and your colleagues work together, what has the pandemic taught you about teamwork and collaboration with other healthcare providers?
Excellent question. So if you think about during the pandemic, we all had our backs up against the wall. This wasn't unique to one hospital, one healthcare setting. We saw this pandemic ravish our older populations, ravish our subacute rehabs and nursing homes. Our hospital was right in the middle of the epicenter of what's happening here in Newark. And I can tell you those were very long days and nights, not only trying to interpret the science and the data accurately, but communicate it in a way that was also sensitive to the concerns and the fears that frontline providers had. And we weren't alone in that. So healthcare was put in a position where we had to share data, we had to share information, we had to share best practices in real time. So Seattle and out west in Washington State in the Pacific Northwest, they had encountered the epicenter before New York and New Jersey. So we had to be able to harvest the lessons that they were able to learn and say, hey, do this differently in your care for these patients, make these considerations, and be in a position to enact them here. So it forced a greater sense of collectivism in the field itself. Doctors are often trained with a very individualistic mindset, but public health is trained differently. And so I sit at a unique nexus of clinical care and public health care, but more broadly, clinical care had to learn how to practice in a matrix environment where we're learning one with another, where we're constantly reevaluating the data or best practice, or reevaluating the status to say, what should I be doing differently? Not only to meet the needs of patients, but to meet the needs of families that are separated from patients. Yeah. I was one of those family members. I couldn't see my father after a certain point. What do we need to do differently? What are institutions doing to meet the needs of their workers? So it was like this evolution of information. You could just feel it, this evolution of information. And even here at University Hospital, we had reservists, U.S. Army, we had reservists come in and help us with our staffing shortages. You can imagine as the explosion of cases descended upon our organization, we were stretched thin. We were stretched thin in every imaginable way. But the ways that community stepped up, whether that was the community of the U.S. Army and sending in reservists, some of which worked with my team, and especially worked with my team in helping to develop peer support groups and networks for our staff that were traumatized and under the stress of an unprecedented public health crisis, or whether that was community who showed up in donation of food, donation of resources to ensure that our staff was okay, or whether it's donations of organizations to say, how are families and patients communicating? How are providers and patients communicating? Are there devices being made available, thinking through at one point, Reginald, we were talking about how to use a baby monitor.
Wow.
How can you use a baby monitor in a healthcare setting, right, to cut down on unnecessary exposure? And that's one of the lessons that we learned, our interconnectedness and the ability to practice as a collective and not just individual or siloed.
And it behooves us to hold on to that interconnectedness.
Yes. Yes.
We will now move to receive questions from our audience, and I'm going to ask Walter to read off the first one.
All right, so as of right now, the one question we have so far is if resources were not an issue, what would you change in the healthcare field? In other words, what would your number one priority be?
I laugh immediately because I'm like, oh, I get happy if resources were not an issue. So allow me to talk about things I would do in parallel. Because if we learned a lesson during this pandemic, the way that we were able to get at a vaccine in the amount of time that we did is because processes that used to be sequential, mean we made them parallel. And I think there is a lesson for all of healthcare in that. How do we make processes that are normally sequential parallel? And the two processes that I would like to see done parallel are investigating, evaluating, and meeting a patient's social needs concurrently while investigating, evaluating, and meeting a patient's clinical or medical needs, because they are not siloed entities. Actually, they are integrated in a human being. But if you're only able to deal with one aspect of what's wrong, then the other aspect that never gets treated just grows and exacerbates, such that the aspect that you think you've solved is risked its benefit or its success quicker or hasten. So what does that look like? That looks like social determinants of health screens. That looks like resources around food insecurity, resources around housing instability. There are a patient that's experiencing homelessness. Yes, he needs medical care, but she needs a place to live. If she has a place to live, her medical conditions would be better controlled and her health status and health outcome would be overall more healthy. The patient who is hungry and cold and comes into your ED may be coming for shelter and a source of food or a meal and not necessarily coming because of a clinical need. So if the more resources that we have to handle, because you as a whole person, you don't say, hey, on this side of me, I'll only deal with this aspect of what's going on this side of me. No, your body works in collaboration, even when I take my two hands and I do this. If I had limitless resources, I would say, what's the diagnosis? And when asking what's the diagnosis, I'm not just saying what's the differential medical diagnosis. I'm saying, what are the social conditions that are ailing this person, or the barriers that are preventing this person from being whole and healthy, and how can we help respond to that? That doesn't mean that healthcare should be able to deliver on all the social resources and needs, but it does mean that we as an industry, as a sector, and that we as a nation need to make different investments in social services. And it has to be on par with the I would say the multiplicity, the plethora of the needs around the social determinants of health.
I just wanted to follow up quickly on your last comment, Dr. Purnell, about investments. And I'm wondering again, as your sector has grappled with and learned about the interconnectedness and ways to better collaborate, what kinds of systemic and or policy changes have you observed in the last, say, 12 months or so, particularly with the Murphy administration, with respect to some of those kinds of investments that we're beginning to see in New Jersey?
Right. So I would say, let's think about it's not the largest, but the latest and largest public health campaign to offer universal care: vaccines. Vaccines right now, in particular, COVID-19 vaccines, are available to all persons regardless of ability to pay. Of course, initially they were rooted in eligibility criteria, but every person, regardless of ability to pay, regardless of insurance status, regardless of immigration status, can get vaccinated. And that is a policy decision. And that is a policy decision, not just rooted in the Murphy administration, but that is a policy decision rooted in a compelling crisis or need. And how does that instruct us in going forward? And I think it's very important that we in public health, again, I'm going to go back to that example of what pharmaceutical companies did and what the federal government, the barriers they've removed. the federal government, through public-private partnerships with pharmaceutical companies, removed barriers around access to clinical research. Hence, some of these companies were able to raise very large trials that they otherwise would not have been able to do. Moderna is an example. 30,000 people, roughly 30,000 people participated in the Moderna trial that I participated in. So the same injection of finances, the same injection of capital that made a solution more accessible in a shortened time frame becomes a precedent. Where else can we have those level of partnerships to deliver on compelling and pressing needs? And the last thing I will say about that is, if we use, let's go back to this example of the vaccines, because it's really illustrative. I want people to understand this is more than about the vaccine itself. It's about the process. Typically, in clinical research, you investigate whether a particular vaccine or even a therapeutic is effective and safe. Once you have an answer about whether or not that therapeutic or vaccine is effective and safe, then you say, how do I mass produce it? How do I manufacture it? During this crisis, because the federal government removed some of the risk, the financial risk associated with that process, pharmaceutical drug companies were able to look at the same time at manufacturing and testing, so that when a product was proven to be safe and effective, the manufacturing and logistical frameworks were thoroughly understood, and we could mass produce hundreds of millions of doses. There are so many lessons and instructions in how policy can be responsive to a need. And so often when we talk about equity, we talk about, what are the unique barriers that this particular group or this particular person is encountering, and giving people resources that match their need. This is an example of leading with a level of equity. Justice, there's this graphic, I can't share with you all right now, but I'll describe it. Justice says, I don't just create a different size height of a ladder. Justice says, if the tree is leaning in one direction, I make the tree upright. So there are opportunities for us to consider policies that have exacerbated inequities, and to evaluate each one and say, what's the policy intervention there? And this isn't particular just to this pandemic, but so let's think about access to Medicaid for pregnant women and women who have delivered in the postpartum period. If you extend that to a year, that's how you begin to make a policy change, a policy intervention that can help to solve the disparate rates of maternal mortality, especially in certain racial and ethnic and socioeconomic groups. And that's what's happening right now. Those are examples.
Thank you so much, Walter. Our next question.
Right, our next question is there a way to short circuit the intervention when someone presents themselves as ill and sick that is late in the game? And is there a trigger that can be focused on that would mitigate the illness earlier or prevent it altogether?
Okay, so let's talk about this specifically through the lens of coronavirus, and then let's talk about this through the lens of a host of other chronic health conditions. What we saw earlier on in the pandemic, we didn't see equitable distribution of testing centers or sites. There was hard to get access to a COVID-19 test, and we often would hear about reports in the media of a person saying, I was turned away. I presented for care and I was turned away. I was told, okay, just go back home. There's nothing we can offer to manage your symptoms here. As our understanding changed and evolved throughout the pandemic, and the let's say ability to test grew, right? Because we were understanding that testing as an appropriate strategy, and people were being identified as having coronavirus and were being given counsel of when it is safe to be treated conservatively and managed at home versus when you needed to be hospitalized and people were being given understanding of warning symptoms, meaning that if you were struggling to breathe or your oxygenation status was deteriorating, these were signs that you could check for in yourself: bluish discoloration, darkened color around the lips or the mouth, the nail bed, panting, rapid respiratory rate. I'm using all of that to say that was our trajectory with coronavirus for how to identify it and then appropriately cohort patients for who should receive what treatment. Then that changed and morphed when monoclonal antibodies became available. And you had certain monoclonal antibodies that were offered as a cocktail, meaning multiple monoclonal antibodies. And these were also things that were being done in an investigative fashion. Right? Our understanding of which groups would benefit the most from these monoclonal antibody cocktails evolved. But then it became, is there equitable awareness? So I would tell people in community, if you get a positive coronavirus test, ask, am I a candidate for monoclonal antibodies? That's how I would instruct people, ask. So prompt the provider to say, am I considering the criteria in this person so that we can give them an emerging therapeutic before their disease state worsens and they're at risk for a more unfavorable outcome. So that was the example through coronavirus. The example through other chronic health conditions is going to take me so upstream that we're going to talk again about social needs. We have to, let's talk about through screening, educate and inform in socially, culturally fluent ways that especially communities that have borne disproportionate burdens of risk, historically excluded groups like Black and Brown groups, understand the value and understand which screens they should receive at which time. So a pap smear to screen or assess for cervical cancer, mammography or a mammogram to screen or assess for breast cancer, colonoscopy to screen or assess for colon cancer, right? To ensure that communities understand the risk, because these are communities that are presenting with later stage disease. But also, we have to think about the environmental conditions. We have to think about the place-based conditions that predispose groups to disease states. And we saw that play out in coronavirus. It's not just that hypertension in and of itself is a risk factor, or obesity in and of itself is a risk factor, or having a chronic lung condition or a cardiovascular disease in and of itself is a risk factor for worse a coronavirus presentation. The upstream factors that make you likely to develop those conditions in the first place are risk factors. And that's the understanding that we have to get to so that we can prevent pandemics and endemic levels of disease.
Thank you, Dr. Purnell. I think we have time for just one more question before we begin to wrap up and stay on time. Walter, you have one more question.
All right, so our next and last question is, will the pace of progress for socioeconomic parity in healthcare be assisted through the policy decisions made at University Hospital? And if so, is there one that you believe to be closely aligned with your strategic vision for the community?
Okay. So I was also reading, that's not only my hope, that's what we want to design. So let me talk a little bit more about our equity roadmap and give a specific example and give an example around housing. So in our emergency department, we can look at data to look at which patients frequently utilize the emergency department. And we can establish a metric around if there's utilization of the emergency department 3 times or more within a 6-month span. In those patients, what are the social risk factors? What are the social determinants of health needs that have been identified that are driving or exacerbating health conditions or are driving health seeking behavior? So one of the initiatives that you increasingly will see healthcare systems participate in, and one of which we at University Hospital are currently exploring a partnership through, is supportive housing. So if I can take the most vulnerable patient, those who are vulnerable by complex social, medical, and behavioral risk factors who would otherwise seek care in an emergency department setting and house those patients in an affordable housing development, where they have wraparound social services. In addition to those wraparound social services, in an affordable housing unit where there is a healthcare center space on the ground level, how does that impact health-seeking behavior, health status, and the bottom line of the of the healthcare organization? That's what I'm talking about. So that's what we're looking to do as a part of our equity roadmap, to establish policy pilots or policy interventions, and to say, do we have the data to prove that this definitely had an impact, not just in disease states, not just in social conditions, but also an impact on the triple and quadruple bottom line of an organization. That's one example. Another example is through procurement, through supplier diversity. Can we say that procuring, purchasing services, purchasing resources, in particular locally and in particular from diverse suppliers, how does that help to achieve economic justice? How does that help to achieve economic viability? How does that achieve economic viability for the city in which we're situated in? And the very, very last example, so I said supplier diversity was one, supportive housing was another, are examples around food insecurity through, making available food pantries, food boxes. On discharge, you just don't get a script, but you get a box of food if you have been identified as food insecure. How does that then impact your disease conditions? How does that impact management of your condition, progression from one stage to the next? So those are the things that we're looking at to demonstrate that truly matters, not just through one lens, but through a holistic lens.
Thank you, Dr. Pernell. I did say to all who have joined us today that Dr. Pernell would not disappoint. We thank her for reminding us of the significance of leading with equity. And we know that the greater Newark community is a healthier place because of you. Now, Dr. Pernell, we promise you that we will send to you our very own Greenleaf mug. And again, we are grateful for your time today. We thank all of those who joined us. Please remember that it is not too late to sign up for our June 4th Foundations of Servant Leadership class. Visit us at greenleaf.org to find out more. Registration is also still open for our International Servant Leaders Summit, taking place on June 9th through the 11th. Find out more by heading to servantleadersummit.org. We're also excited to share the news that tomorrow, the center will launch its next generation initiative with a new pilot with the Orange Public Schools. I know something near and dear to Dr. Purnell's heart. We will be introducing graduating seniors to the principles and practices of servant leadership. And for the next several weeks, these young people will serve as Orange ambassadors of service. We hope to see you next month when our guest in the coffee series will be Maria Viscarando, President and CEO of the Council for New Jersey Grantmakers and former CEO of the United Way of Newark. Many thanks again to everyone who spent time with us today. And again, many thanks to you, Dr. Purnell. We'll see everyone next month. Bye-bye.
Thanks for having me. Have a good day, everyone.